Well, I guess so. I mean, I think there's particular interest in value-based pricing, which is due to begin in 2014. And the principle there, from the government's perspective, is that the price we pay for prescription drugs will more fully reflect on an individual drug basis the value of the product. Now, of course, in principle, that's an applehood and an apple pie scenario. Really, because the devil's in the detail about exactly how you define value and how you operationalise the scheme. So, as an economist, my view is a value essentially it's about how much health gain you generate from the new technology compared to how much health gain you forego by displacing services to find sufficient resource to fund the new services. So the idea, if you spend another £10 million on a cancer drug, that £10 million has to be found from other activities within the system. We might do less hernia operations, we might spend less on care of the elderly and so forth, and that results in health decrements in the system. So it's about balancing the health gains and the health decrements. And we do that through cost effectiveness analysis and looking at the extent to which the cost per quality is below the cost effectiveness threshold. That's how NICE operationalise it. So the idea will be that the value-based price is the one which essentially gets you to a point where the incremental cost effectiveness ratio is just below the cost effectiveness threshold. But there's a huge amount of detail to sort out, and it could be a great scheme or a poor scheme depending on that detail.
I think that's a lovely thing to come in on as a clinician, because up till now I've had to go and learn health economics so that I can discuss cost per quality. But in 2014, when value-based price comes in, they're going to come back to me and say, how do I value a particular disease state compared to another disease state that I'm seeing in the next room or the next bed? And I'm going to actually involve the patients in that, and then it'll all be about the panelists that choose what is the value of a particular drug impact. As an example, let's take atrial fibrillation. Now, to prevent stroke is quite impressive, but actually you're only preventing strokes for a small number. So for those individual patients, you do quite well, but for the global group that have atrial fibrillation, you're actually not doing very much. You're just putting them on medications that will thin their blood down, that will actually increase risks for some of those patients as well. But there'll be more emotional diseases where preventing the stroke is going to be the most critical thing. If you've already had an intracranial hemorrhage and you have atrial fibrillation, you definitely don't want a thromboembolic stroke on top of that. So for those patients, I'm going to be able to say to Mark, for that niche of groups, that's going to be a much more important cost per quality than the generic cost per quality we do for the entire cohort of patients with atrial fibrillation. And we'll be actually able to talk on similar terms, and I won't have to fight my colleagues for that same £10 million that I've displaced into something else. We'll actually be able to make a decision. Well, what am I really going to get more from? This patient who's at critical risk of another disabling stroke, who's not going to die, who's actually going to survive it and actually use so much more resources, or a couple of hip operations from the patients that actually are the worried well. They're actually the ones that complain more. They're not actually the ones that are disabled more.
No.
And we're going to be able to talk about that in a more open framework. And I think that'll be interesting times.
And will patients actually be able to override the decisions from their willingness to pay for drugs that actually the doctors and the health economists don't think are of value?
Well, I hope not, because ultimately this is a system. What we're trying to deliver with a system like the NHS, and it's true of course many other systems around the world, is from a fixed budget to deliver healthcare for a population. So in principle, one patient's choice is a limitation on another's choice. Okay.
Isn't that only if the patient isn't willing to pay for it, though? If they pay for it themselves.
Okay. Well, the role of individual payments and co-payments from patients, of course, is a contentious issue. In principle, you're right. If the system doesn't consider a product to be of sufficient value, then the patient can, in principle, purchase it themselves or potentially top up something that's already funded or partly funded by the NHS. But we have to be aware, of course, that there are some potentially major equity implications of that. In the patients who are sufficiently wealthy to afford those sorts of payments, in principle, get gains in their health. And as a society, we may well be interested, I hope we're interested, in the inequalities in health rather than simply maximising population health. So these are complex and difficult issues, And again, that's why the detail of these arrangements really matters.
Yeah, I think that's a slightly divisive question of yours about patients overriding it, because if you look at the broad majority of patients that require healthcare, they're over 60. They haven't all got the affordability to go out and buy their own medications. They've been saving what little they had, and we keep using it up to say, well, actually, we're not even going to fund your nursing home beds anymore. You're going to have to sell your house before we do that. And then we're going to ask them to buy their own medications if we haven't allowed that. You know, so perhaps the newer generation are getting used to putting nest eggs aside, but the older generation haven't got that mentality. It's almost unfair to thrust it on them. I actually think the UK is a great cutting-edge place where if there's a fixed budget, you've got to make rational decisions. And actually, the majority of patients are actually fairly sensible. Now, of course, the emotive mother with a child that's got this, of course, she's got a bigger case to make. But the majority of the older patient group, they understand about this opportunity loss. I'm actually quite impressed by their rationalisation of it all.